Bismillah ar-Rahman ar-Rahim. Today, our lecture about the biliary system. First, we will speak about the surgical anatomy. Gallbladder shape. The gallbladder is pear-shaped with normal capacity of about 50 ml. Location in the visceral surface of the liver at the plane dividing it is two surgical lobes. And the gallbladder can be divided into fundus, body, infundibulum, and neck. Common hepatic duct. The common hepatic duct is formed by union of the right and left hepatic duct in the porta hepatis. The cystic duct is about 2 to 3 centimeter long and 2 to 3 millimeter in diameter. Its mucosa is thrown into crescent-like fold called the spiral of valve of Hester. Common bile duct. The common bile duct begins at the union of the cystic duct and the common hepatic duct and ends at the ampulla of water in the second part of the duodenum. Length it varies from 8 to 10 centimeter and the average diameter is about 6 millimeter. The common bile duct can be divided into 4 parts: the supraduodenal, retroduodenal, intrapancreatic, and intraduodenal part. The supraduodenal part, about 2.5 centimeter long, and runs in the free margin of the laser omentum. The intraduodenal part passes through the wall of the second part of the duodenum, where it joins the main pancreatic duct and together form the dilated segment that is known as the ampulla of water. The latter opens in the middle of the second part of the duodenum on the major duodenal papillae. The common opening is surrounded by the sphincter of Oddi. Blood supply, arteries. The gallbladder is supplied by the cystic artery, which arises from the right hepatic artery. The extrahepatic bile duct are usually supplied by cystic artery above and gastroduodenal artery below. The blood vessels supplying the duct usually runs longitudinally at the 3 and 9 o'clock position. Veins. Venous return consists of small veins that directly enter the liver bed and of cystic vein that enters the right branch of the portal vein. Lymphatic drainage. The lymph vessels of the gallbladder drain into the cystic lymph nodes of Lange. Nerve supply. We have parasympathetic and sympathetic supply. The parasympathetic vagal fibers arise from the hepatic division of the anterior vagal trunk. Parasympathetic supply is responsible for the contraction of the gallbladder, whereas the sympathetic fibers reach the celiac plexus by way of the greater splanchnic nerve. Bile secretion amount daily from 250 to 1000 ml per 24 hours. Control, neurogenic and hormonal control. Neurogenic through the vagal stimulation increase secretion, and splanchnic stimulation decrease the bile flow, whereas the hormonal bile flow is stimulated by the secretin release from the duodenum, which itself is stimulated by hydrochloric acid, protein breakdown products, and fatty acids. Composition of bile: water, electrolytes, bile salts, cholesterol and phospholipids, and bile pigments. Gallbladder function is storage of the concentrated bile, mucus secretion to protect the mucosa from the lytic action of the bile, and gallbladder contracts and empties its content when the bile is needed for digestion. Imaging investigation. Abdominal X-ray. This test is limited value. It can detect the stone in only about 10 to 15% of cases. A gallbladder with calcified wall, porcelain gallbladder, can be visualized. Presence of air in the gallbladder can be seen in acute emphysematous cholecystitis, while air in the biliary system is present after cholecystoduodenostomy. Choledochocole duodenostomy, and sphincterotomy operation. Abdominal ultrasound to detection of the gallbladder stone in about 98% of cases. It is less accurate in the detection of the stone in the CBD, detection of the thickness of the wall of the gallbladder in cases of acute or chronic calculocystitis, visualization of the dilatation of the extra and intrabiliary ducts, and detection of masses in the porta hepatis or head of the pancreas. And this is the picture about the plain X-ray of the abdomen and the abdominal ultrasound. Endoscopic retrograde, the other tools for investigation is the endoscopic retrograde cholangiopancreatography أو ما يعرف ب ERCP. Methods: this is machine that enter through the esophagus and stomach and reach to the duodenum, and the duodenal papilla is located and the cannula is passed in it, and a contrast material is injected to visualize the common bile and the pancreatic duct by radiography. Indication for diagnosis of lesions involving the lower ends of CBD as carcinoma of the head of the pancreas or ampulla of Vater, and taking a biopsy, or detection of missed calculi in CBD after cholecystectomy, and detection of operative injury of the biliary system. And it has also therapeutic purpose. Therapeutic procedures can be performed with the RCP, example, sphincterotomy and removal of the bile duct stone, and insertion of the stent to drain the malignant obstruction of duct. Complication of ERCP: the presence of unrelieved obstruction in the CBD. Injecting of the contrast material may lead to the cholangitis or even septicemia due to increased pressure in CBD, as well as acute pancreatitis or duodenal perforation may occur as a complication of ERCP. The other tool is the percutaneous transhepatic cholangiography, what we call it PTC. Technique is injection of dye under local anesthesia by Sheba needle, and to visualize the dilated intrahepatic part, and to visualize the ducts and follow the bile duct from the above downwards. Indication of PTC: to diagnose a high obstruction in the bile duct, as in post-operative biliary stricture or inhaler cholangiocarcinoma that occur in the common hepatic duct. Complication: bleeding may occur if there is hypothrombonemia and biliary proteinitis. Other imaging investigation is the radioisotope scanning to diagnose the acute cholecystitis and to visualize the gallbladder. Non-visualization of the gallbladder indicates obstruction of its neck and support the diagnosis. A gallbladder that failed by the isotope is excluded it. Diagnosis of the congenital biliary atresia and to visualize the biliary intric anastomosis. Magnetic resonance cholangiopancreatography, what we call it also اختصارا is MRCP, is expensive but can provide a good quality imaging without the complication associated with the ERCP or BTC. Now we will start the congenital anomalies. Congenital anomalies of the biliary tract are found in 10% of autopsies after death. Anomalies of the gallbladder: it can be absence of gallbladder. It occurs in 0.03% of cases. Pharyngeal cup, double gallbladder, floating gallbladder, left-sided gallbladder is extremely rare, and intrahepatic gallbladder can occur and associated with the increased incidence of gallstone. Anomalies of bile duct: either biliary atresia, choledochal cyst, Hepatic duct anomalies. Accessory hepatic duct may enter into the cystic duct or into the neck of the gallbladder. The right, left, or even both hepatic ducts enter to the gallbladder directly. Cystic duct anomalies. Absence of the cystic duct, low insertion of the cystic duct, or cystic duct may enter the right hepatic duct, and this can be mistaken for cystic duct and can be ligated and injured. Anomalies of the hepatic and cystic arteries. Accessory cystic arteries, more than one artery. A large accessory left hepatic artery may arise from the left gastric artery in about 5% of people. The right hepatic artery may arise from the superior mesenteric artery, and the right hepatic artery may pass in front of the or behind the common hepatic duct or common bile duct and may be mistaken for the cystic artery and can be ligated easily. Now we'll enter for the disease of the biliary system. The first one is the gallstone. Incidence. There is geographical variation in incidence of gallstone, being more common in Western countries. Female to male ratio about 3:1, reported in cholesterol and mixed stone. The incidence of gallstone increases with age, and there is also familial incidence of the disease. Types and composition. We have pure cholesterol stone, mixed stone, and pigmented stone. Pigmented stone, either black pigmented stone or brown pigmented stone. Etiology of cholesterol and mixed gallbladder stone. We have disrupted bile salt cholesterol ratio, as in the reduced bile salt pool or increased cholesterol synthesis, and stasis of bile, especially in the female hormones, and following truncal vagotomy, diabetes mellitus, obesity, and long-term parenteral nutrition. All of these are leading to the cholesterol or mixed stones. Pigmented stone related to the hemolytic anemia, any condition that shortens the lifespan of the RBCs, as in the hereditary spherocytosis or thalassemia or prosthetic heart valves, may be associated with the black pigmented stone. Liver cirrhosis as well as the infection play a role in the formation of the brown pigmented stone. Most gallstones are silent and remain so in 70% of patients, being diagnosed as an incidental finding, usually on ultrasound for other purpose. Symptoms like recurrent biliary colic develop in 2 to 3% per year. Each year, 3 to 5% of symptomatic patients develop complication. Thus, prophylactic cholecystectomy for silent stone is rarely indicated. Complication of gallbladder stone. Obstruction of the cystic duct of the neck of the gallbladder, leading to mucocele or leading to the empyema or gangrene or perforation. Chronic cholecystitis, the gallbladder is usually thick-walled and is commonly contracted. Carcinoma of the gallbladder. This is a serious complication for long-standing calcular disease. Is in the development of squamous metaplasia of the gallbladder followed by the carcinoma. About 90% of the patients with the carcinoma of the gallbladder have gallstone. Other complications related to the migration of the stone. If migration of the stone to the common bile duct, it can occur in the obstructive jaundice, cholangitis and cholangitic abscess of the liver, acute pancreatitis, and rarely long-standing intermittent obstruction leading to biliary cirrhosis result. Migration of the stone to duodenum through the out fistula. Gallstone ileus is a rare complication, a big stone more than 2.5 centimeters that pass through the fistula between the gallbladder and duodenum may get impacted in the terminal ileum and about 2 feet from the ileocecal valve and call it gallstone ileus. Clinical pictures of gallbladder stone. Accidental discovery of silent gallstone, recurrent attack of biliary pain, biliary dyspepsia, reflex symptoms, and complication. How investigate the patient with the gallstone? We plain X-ray as before we speak about and abdominal ultrasounds. The standard treatment of the gallstone is the cholecystectomy, that means removal of the gallbladder, either by laparoscope technique or by open technique. Acute calcular cholecystitis. It is in the majority of cases, about 98%, acute cholecystitis is secondary to the obstruction of the cystic duct or heart-mount pouch by stone. Pathogenesis, obstruction of the cystic duct or neck of the gallbladder by stone and subsequent infection, usually gram-negative bacilli, result in acute cholecystitis. And gross appearance, the gallbladder is distended, its wall is thickened, and it is serosal lining loses its normal bluish luster and the covered by the fibrinous deposit. Consequences of the acute cholecystitis, either resolution or less commonly obstruction persist with progressive distension and perforation of the gallbladder may occur followed by either localization or less commonly generalized peritonitis in about 0.5%. Acute emphysematous cholecystitis, empyema of gallbladder, that's mean pus inside the gallbladder, recurrent attack lead to the chronic calcular cholecystitis. Clinical pictures of the acute cholecystitis. Initially, the patient complained from diffuse colicky upper abdominal pain similar to the biliary colic. With inflammation of the serosal covering, pain become full aching, persistent with and localized in the right hypochondrial region. Pain may be referred to the right shoulder due to irritation of the undersurface of the diaphragm supplied by the sensory fibers of the phrenic nerve. Pain persisting more than 6 hours usually denote acute cholecystitis, whereas the pain of the biliary colic without inflammation lasts about 2 hours and disappear. There is usually nausea and sometimes vomiting. Examination, usually there is pyrexia and tachycardia. Abdominal examination reveals tenderness, rebound tenderness and muscle guarding in the right hypochondrium. And we call it the psoas sign when put your finger in the 9th rib at the mid-clavicular line and ask patient to take deep breathing. He stopped the breathing and because he feels the severe pain. Rarely, a large stone impacted in the heart-mount pouch may compress the bile duct leading to jaundice and what we call it Merisi syndrome. Differential diagnosis of acute cholecystitis: perforated duodenal ulcer, acute pancreatitis, high retrocecal appendicitis, right pyelonephritis, and amoebic hepatitis. Investigation, laboratory, complete blood count, so the leukocytosis and liver function usually normal. Imaging, abdominal ultrasound, and hide scan to see the wall thickness and the gallbladder stone. Treatment. There are 2 options, but ultimately the definitive treatment is cholecystectomy. That's mean removal of the gallbladder to prevent further complication and to prevent the symptoms of the patient. Early cholecystectomy within 3 days of onset of attack. So long the diagnosis is confident, that means you get the diagnosis of acute cholecystitis, a patient is fit and the surgeon is experienced, early cholecystectomy is now recommended. That means before 3 days. If patient come to hospital after 3 days, so here we go with the conservative treatment. Initial conservative treatment followed by cholecystectomy after 6 weeks. We put him nail per mouth and IV fluid, antibiotic against the gram-negative bacilli by ampicillin or cephalosporin, analgesics by betadine or non-steroidal anti-inflammatory drug, and to avoid the use of morphine, because morphine, it can lead to the contraction of the sphincter of Oddi. Follow-up of pulse, temperature, area of tenderness and rigidity. Under this treatment, most patients improve and attack subsides. And after that, discharge the patient and ask him to come back after 6 to 8 weeks to do for him elective cholecystectomy after subsides of adhesion. If the conservative treatment, the patient deteriorates and surgery should be performed, here we will, I mean that when put the patient in conservative treatment, and this conservative treatment not patient not get good from this conservative treatment and enter into complication, you should go with the cholecystectomy. That means open of the gallbladder from the fundus and remove the stone and make drain out, and after 6 to 8 weeks let the patient to come to do for him cholecystectomy. Acute non-calcular cholecystitis, this is a rare condition and serious condition which may occur in patients suffering from major burns or major trauma, patient on prolonged total parenteral nutrition. It may complicate certain infection as brucellosis or typhoid fever. Acute non-calcular cholecystitis, the actual cause and pathogenesis of the condition is unclear. Change in the composition of bile or ischemia of gallbladder may be responsible. The clinical picture similar to that of the acute cholecystitis, but usually the diagnosis is delayed because it is not suspected. Ultrasound examination is diagnostic, and treatment also by cholecystectomy. Cholecystectomy, removal of the gallbladder, is an operation which needs wide knowledge of the anatomy and congenital anomalies of the biliary tree. It requires meticulous dissection. If performed by a competent surgeon, it has a low morbidity and mortality even in difficult cases. Indication of cholecystectomy: gallstone, stone in that cause biliary colic, acute calcular cholecystitis, common bile duct stone, silent gallbladder mentioned previously, and acute non-calcular cholecystitis and carcinoma of gallbladder. All of these are indication for removing of gallbladder. That's mean cholecystectomy. It can be done, this picture show it can be done as laparoscopic cholecystectomy by use of 4 holes and or by open cholecystectomy under general anesthesia, both of them. Laparoscopic cholecystectomy advantage: post-operative pain is less severe as there are only 4 small ones. Post-operative stay in the hospital 1 day, and nowadays they are making for 12 hours, and you can discharge day case surgery, and you can discharge the patient after procedures. Post-operative follow-up smooth and rapid, early return to work, and better cosmetic results. Contraindication of laparoscopic cholecystectomy في حالات البريجنانسي, carcinoma of the gallbladder, bleeding diathesis, and compromised patient of cardiovascular or respiratory condition. Complication of cholecystectomy: hemorrhage, biliary leak, subphrenic collection of bile, jaundice, and post-cholecystectomy syndrome. Non-biliary cause: the original diagnosis might be wrong from the beginning. Biliary dyskinesia or problem related to the operation as miss stone in the common bile duct. All of these symptoms can lead to what we call it post-cholecystectomy syndrome. المريض يبقى يشتكي دائما as acute cholecystitis after removing of gallbladder. Common bile duct stone: about 15% of patients with calcular cholecystitis have a stone in the common bile duct. Bile duct stones are called cholelithiasis. Pathology, formation. In most cases, stone in the common bile duct is originally formed in the gallbladder, then descend to the CBD. Primary stone in the CBD are rare and occur when there is prolonged stasis and infection. These stones have the chemical composition of brown pigmented stone. Sequelae, if the stone in the common bile duct is floating, يعني تسبح, no effect. Passage of the duodenum, a small stone usually less than 3 mm, can pass spontaneously through the sphincter of Oddi. During passage, it may produce acute pancreatitis. Obstruction of the CBD leading to the obstructive jaundice, dilatation of the bile duct intrahepatic biliary radicals. In the presence of the prolonged obstruction, a high pressure in the bile duct, bile secretion by the liver is stopped, and the bile duct become full of mucus, white bile. Complication of stone in the common bile duct leading to bleeding tendency because of failure of absorption of fat-soluble vitamin, including the vitamin K, cholangitis, especially with the gram-negative bacteria, and leading to the severe infection of the liver or even septicemia or liver abscess. Septicemia and hepatorenal failure, acute pancreatitis, and biliary cirrhosis. Clinical picture, symptoms. It can be silent if the stones are floating, no symptoms, or pain in the right hypochondrium and epigastric area would refer to the right scapular region or even to the back. There may be nausea and vomiting. Jaundice, calcular obstructive jaundice, usually slowly, progressive, fluctuating, and usually does not reach to the severe degree. Calcular jaundice is in obstructive, native with the dark frothy urine and pale stool and pruritus. We have charcot-tried and Reynolds Bintad. Charcot-tried due to super added cholangitis. The patient gives history of recurrent attack of pain, jaundice, and fever and rigors. Reynolds Bintad is charcot-tried, that pain, jaundice, fever, and rigors, added to altered mental status and shock. This is important. If the patient have charcot-tried or Reynolds Bintad, that means patient enter with the cholangitis. Examination, we see the degree of jaundice, temperature, signs of hepatocellular failure, signs of bleeding tendency, itching markers, and distended gallbladder, which we call it Curvature law. Differential diagnosis of calcular obstructive jaundice, hepatocellular jaundice due to viral hepatitis or drug toxicity, or malignant obstructive jaundice due to carcinoma of the head of the pancreas or cholangiocarcinoma of the bile duct. Investigation, as we mentioned before, blood picture during attack of the cholangitis, we get the leukocytosis. Liver function test show the increased level of the all from bilirubin and alkaline phosphatase, as well as the SGOT, HBT, and prothrombin time is long, and fecal sterobilinogen and urinary urobilinogen are diminished. Abdominal ultrasound to see the imaging tools to see the causes of the obstructive jaundice. Abdominal ultrasound shows the dilatation of the intra and extra biliary 3, diameter of the CBD, presence of chronically inflamed gallbladder with calculi, presence of stone in CBD, a mass of, in the head of the pancreas may be detected. Abdominal CT scan, ERCP or MRCP, all are used for diagnosis of the common bile duct stone. Management of the calcular obstructive jaundice, the aim to relieve the biliary obstruction by removing of the stone from the CBD and to remove the gallbladder that usually the source of the common bile duct stone. Perioperative preparation, this patient with the obstructive jaundice, it should go with the preoperative preparation before enter the operation. In the absence of cholangitis, calcular obstructive jaundice, it's not an emergency. The patient can be admitted to the hospital for a few days during which he receives injection of vitamin K, correct to the coagulation abnormalities, adequate hydration by giving good hydration by IV fluids. Oral bile salts may diminish the ability of endotoxemia and renal failure, and use mannitol if urine output is not stays factory, and broad spectrum antibiotics to prevent patient to enter with the cholangitis. Definitive treatment, if the patient is debilitated with the suppurative cholangitis, temporary relief or biliary obstruction can be achieved by BTD or stent insertion by BTD or ERCP, and definitive management postponed until the patient is fit for surgery. Treatment is indicated for both silent and asymptomatic common bile duct stone. In two situations, the treatment is indicated. Definitive treatment, if ERCP is available, we can do the extraction of the stone through the ERCP, and after that, patient enter for cholecystectomy. If ERCP is not available or if failed to clear the CBD stone, treatment by the operative exploration of the common bile duct and removal stone and put the T-tube, and this called cholecystectomy and choledocholaectomy. Possible complication of ERCP, as mentioned before, bleeding, cholangitis, and pancreatitis. And this is the picture to show how to do the T-tube after exploration of the common bile duct if the ERCP failed to manage the CBD stone or if ERCP not available. Additional procedures to prevent further obstruction. Indication: residual inaccessible stones, example in intrabiliary duct, or impacted stone in the lower end of the CBD, or stricture of CBD. All these indication, the RCB or the exploration of the common bile duct with D-tube, it's difficult. So we have other choice for treatment like choledocholaectomy. That means anastomosis between the common bile duct to the duodenum, first part of the duodenum, if the CBD caliber is more than 2 centimeters, or transduodenal sphincteroplasty if it is stone less than 2 centimeters, and all this choice is indicated as we told in residual inaccessible stone or impacted stone in the lower end of the CBD or stricture of CBD. Jaundice. Jaundice is a yellowish discoloration of the body tissue and fluids, except the brain, CSF, tears, saliva, and milk, which result from accumulation of bilirubin in the blood. It become manifested when the serum bilirubin exceeded 2.5 milligram per deciliter. You know the bilirubin metabolism, RBC destruction, breakdown of the hemoglobin to globin and heme, biliverdin and bilirubin formation, bilirubin conjugation and bilirubin excretion, change in the intestine and reabsorption. Types and etiology. Types of jaundice. We have three types of jaundice: hemolytic or prehepatic jaundice due to excessive destruction of RBCs, which occurs in various types of hemolysis. Hepatocellular or hepatic jaundice in viral hepatitis, decompensated liver cirrhosis, or some drugs. Obstructive or post-operative jaundice cause in the lumen of the bile duct, cause in the wall of the bile duct, or cause outside of the bile duct. Clinical picture of obstructive jaundice. General examination focus on pallor, pyrexia, degree of jaundice, cachexia, stigmata of liver insufficiency, bleeding tendency, and edema of the lower limb. Patients with the hemolytic anemia usually have hepatomegaly and splenomegaly. In calcular obstructive jaundice, abdominal examination is usually negative. In malignant obstructive jaundice, the liver and gallbladder are commonly palpable. Ascites may be present in advanced cirrhosis or in metastatic malignant lesion. Investigation: blood picture to see the hemoglobin and the WBC for leukocytosis, serum bilirubin, SGOT and SBT, alkaline phosphatase, prothrombin time and concentration, and partial thromboplastin time, serum albumin, and fecal stericoplasmin. Investigation by imaging: abdominal ultrasound. This is undoubtedly the first investigation to order and demonstrate the dilatation of the intrahepatic biliary radicals in patients with the obstructive jaundice. CT scan particularly indicated in patients suspected of having abdominal malignancy, ERCP, as well as the BTC. Thank you for listening for this lecture, and this lecture is the last lecture in the GIT system.